Hello everyone, welcome to your lecture on Phase 4 studies. We're going to be looking at observational drug safety studies in this lecture. So just to orient you a little bit more with respect to what we're talking about today, I know you've seen this figure a number of times now in this class, but it's important because it's what the entire class is about, the drug discovery pipeline. So of course, we already talked briefly about how a medication is, how the drug discovery process works here, how preclinical and Phase 1 and Phase 2 studies are conducted, and especially Phase 3 trials. So we spent a ton of time talking about Phase 3 randomized controlled trials and how to conduct them properly. And of course, you're doing your RCT project right now. So that's all about clinical trials to determine the safety and efficacy of a new medication. And of course, if a medication has demonstrated safety and effectiveness, then it will be approved for use on the market, and physicians will be able to prescribe this medication. So you should have already watched your lecture from David, where he talked a little bit more about pharmacovigilance and post-marketing surveillance. So he would have talked about this from the drug company perspective and all of the activities that a drug company or manufacturer is required to undergo or undertake in order to confirm the ongoing safety and effectiveness of a medication once it's been approved for use on the market and people from all over the world are using it. So David mentioned that a lot of the time, a safety signal might come up as a medication is being used by more and more patients, and that's an observational study. But a lot of the time we need to look further into this particular safety signal where we complete an observational drug safety study, which I'm going to get into the details of a little bit more right now. So I discussed this a bit in the trials lecture, but just as a reminder why we conduct observational drug safety studies after they've come onto the market, and why clinical trials aren't enough to determine the safety and effectiveness of medications, and why Phase 4 studies need to be done in the first place. As I mentioned, in randomized controlled trials, typically very homogeneous populations are enrolled in RCTs, and mainly include relatively healthy patients with only one disease, and exclude specific subgroups of individuals such as pregnant women, children, or older adults. So in observational drug safety studies or Phase 4 studies, we might be interested in determining the safety of a newly marketed medication within pregnant women or within children or older adults. So that's one reason we might go on to conduct a Phase 4 observational drug safety study. Small sample size, so of course you only enroll a few thousand patients in a randomized controlled trial, so it's very expensive to conduct. But once a medication has been approved for use on the market, you can actually study hundreds of thousands of people who are using particular medications. So this gives us the opportunity to actually look at rare events or rare adverse events that weren't actually evaluated in randomized clinical trials. Again, RCTs have a limited duration, so some adverse events such as cancer could not be evaluated because of the limited duration of a randomized controlled trial. And a lot of the time, randomized controlled trials are conducted in a very defined environment, in a very controlled environment, and real world clinical practice is very different than a clinical trial setting. So it's important to understand how a medication actually treats a patient in a real world clinical setting when they're not being constantly and consistently evaluated by a physician or by a study team. And this is just some additional information on the differences between observational evidence and RCT evidence. So additional limitations of RCTs include them being costly and time consuming. Again, they're designed to answer a very narrow hypothesis in a targeted population. And there's other questions that arise in clinical practice that RCTs can't answer. So again, similar to the other side, a specific population might be excluded, like older adults or pregnant women. A safety outcome wasn't measured that is coming up as a potential safety signal from some pharmacovigilance reports that are being collected. Combinations of medications might not be considered, and a relevant comparator might not have been studied. So in real-world clinical practice, another medication might be used to treat the same indication, but the RCTs don't actually compare to that medication. So we might want to look at the comparison of those two medications to provide better evidence for prescribing decisions in real-world clinical practice. So again, observational studies address these knowledge gaps without exposing patients to experimentation. And as I mentioned, they can also allow us to follow up on potential safety signals from other pharmacovigilance activities. So overall, it's just important to keep in mind that the take-home message is randomized controlled trials have a particular time and a place for when they're important, and they're absolutely essential in for the approval of new medications entering the market. However, there's a lot of questions that randomized clinical trials cannot answer for all the reasons I just gave, and that's why it's essential to continue to study the safety of a medication after it's been approved for use on the market and everybody is using it, or people have been prescribed the medication. So just to help you understand what the difference is between experimental studies and observational studies, I'm going to give you a quick overview of these two study designs. So you already know all about experimental studies. Experimental studies are randomized controlled trials or clinical trials where subjects are randomly assigned to be exposed or unexposed. So to the treatment, the new medication, or they're randomized to the control group or the placebo. And we know that the only difference between the exposed and unexposed groups is the new medication treatment itself. And in these particular studies, we evaluate the efficacy and safety of a new medication in the situation where genuine uncertainty exists as to whether a treatment is best for a population of interest. And I mentioned this in another lecture. This is called clinical equipoise. Those also are experimental RCTs that we're already very familiar with. In contrast, observational studies are studies where the investigator plays no role in the exposure, and this is very, very important to keep in mind. Exposure or drug treatment, of course, occurs based on a patient's characteristics or is chosen by a subject. So, a patient isn't being randomized to treatment in the real world. A patient is being prescribed a medication in the real world as a result of the characteristics that they have. So, for example, in our rofecoxib example, patients with rheumatoid arthritis have pain, and that's the indication for treatment. So when they're sitting in the doctor's office and they have pain from their rheumatoid arthritis, they might be treated they won't be treated with rofecoxib anymore because it's been taken off the market, but they would have been prescribed rofecoxib or naproxen, for example. Naproxen's still on the market. That's another anti-inflammatory medication. They would have been prescribed that medication because of their pain and because they had the indication for treatment. They weren't randomized to one or the other. A particular treatment was chosen for them based on their characteristics. So that's really, really important to keep in mind. So observational studies, therefore, exploit this natural variation in drug exposure in a population in order to evaluate the safety and effectiveness of medications that are currently on the market. So overall, it's important to keep in mind that observational studies seek to achieve the same thing as a randomized controlled trial. They answer a PICO question or a research question, but they're not a controlled experiment. Again, study investigators do not randomly assign the treatment, and physicians prescribe medications based on patient characteristics. So those are the main distinctions that you need to be aware of between experimental studies, which are randomized controlled trials, and then observational drug safety studies. So as an example, we're going to use this particular paper as a little case study as an example throughout this lecture. So this study was a paper published by Daniel Solomon and colleagues, and it was related to the relationship between selective cyclooxygenase 2 inhibitors and acute myocardial infarction in older adults. So this is rofecoxib, the COX-2 inhibitors. So just remember, I know some of you did Vioxx in your drug life cycle assignments, but this medication was actually taken off the market because it had adverse cardiovascular outcomes. So this particular study, the reason that they conducted it in the first place, they point out, is the fact that in clinical trials, COXIBs, which is rofecoxib and celecoxib, were medications that were developed to treat pain and inflammation, and were used because they were thought to cause less gastrointestinal hemorrhages as compared to NSAIDs, which are also anti-inflammatory medications used to treat arthritis and other pain conditions, but have a lot of adverse GI events associated with the medications. So that was the whole reason why these medications were brought onto the market, because it was thought that they had a better safety profile compared to NSAIDs with respect to GI hemorrhage. But after the medication had been brought onto the market, the COXIBs, that entire class of medications, there had been growing concern about their cardiovascular safety from a number of different case reports and other safety signals in the post-marketing drug surveillance work that was what was being done. So what this study did was they looked at the relative risk of acute myocardial infarction among users of COXIBs and compared that to NSAIDs. And this is among Medicare beneficiaries. So these are just people who are over the age of 65 living in the U.S. So this isn't going to make a lot of sense, this method section and results section right now, but I'm going to, go through the main points of it, and then you'll learn more about how to understand all of the different components during the course of the lecture. So in this particular study, they conducted a matched case control study. So this is a nested case control study of about 54,000 patients who received their medication through the U.S. Again, these are Medicare patients. All healthcare use encounters were examined to identify hospitalizations for acute myocardial infarction. That's how they identified the outcome of interest. They found that there are about 10,895 cases of acute myocardial infarction, and then they matched those cases with 4 controls on age, gender, and month of the index date. So then they conducted a matched logistic regression model in order to account for these patient confounders, including patient demographics, healthcare use, medication use, and cardiovascular risk factors. And then they assessed the relative risk of acute myocardial infarction in patients who use rofecoxib compared to those using no NSAIDs or taking celecoxib or taking NSAIDs. So with respect to their main findings, they found that current use of rofecoxib was associated with an increased relative risk of AMI compared to celecoxib. So they calculated an odds ratio, and this is an adjusted odds ratio, where they found that there was about 24% increase in the risk of myocardial infarction, and the confidence interval ranged from 1.05 to 1.46, which indicates the data is consistent with an overall increase in the risk. It could be as small as 5% or as large as 46%. And with no NSAID use, when the comparison between rofecoxib and no NSAID use was evaluated, this was a 14% increased risk. And then they looked at differences in the doses. And then they looked at differences in the duration of use as well. So overall, this study found that current rofecoxib use was associated with an elevated relative risk of acute myocardial infarction compared with celecoxib use and no NSAID use. And they described the dose response and the duration of response relationship. So again, this probably doesn't make a whole lot of sense right now, but just keep all of these in mind, and we're going to learn about, what a nested case control study is, what an adjusted analysis is, later on throughout the lecture. So now after that introduction and a few case studies and looking at, the place of observational studies in the drug life cycle and how they differ from randomized controlled trials, I'm going to get into the details now of observational studies, and I'm going to start talking about observational study design. So again, there's two different types of study designs. There's observational studies and experimental studies. So again, just as a reminder, experimental studies or randomized controlled trial, when we actually assign a treatment to patients, we randomly assign treatment to patients. But in observational studies, we just observe what treatment a patient has received in real-world clinical practice as a result of their characteristics. So examples of observational studies are cross-sectional studies, case-only studies, cohort studies, and case control studies. And typically in pharmacoepidemiologic studies, we focus on cohort studies because in cohort studies, we're able to follow large groups of patients for long periods of time, and we're able to follow them from the start of their medication treatment right until the end of when they either experience the outcome of interest or leave the study or are censored. So these other types of study designs exist, but aren't typically common in pharmacoepi. There's a lot of case-only studies. They're called case crossover studies, where within a single individual, you look at the effect of a medication when they're taking it, and you measure the outcome. There's a washout period, and then you look at whether an outcome occurs after a patient has stopped taking a medication. So those are case-only study designs, but we're not going to be looking at that or discussing that in this course. We're really going to be focusing on cohort studies as well as case control studies, which are nested within cohort studies. But I'll give the details of that later on. So one of the most important distinguishing features of observational studies is the use of real-world data. So what do I mean by real-world data? Well, in order to conduct an observational study, we typically look at data that relates to patient health status and or delivery of healthcare that have been routinely collected from a variety of sources. That's the data that we use. So for example, this can include things like electronic health records, medical claims and billing data, product and disease registries, as well as patient-generated data, including in-home use of medications or other types of data collected from mobile devices. So that's what I mean by real-world data. It's data that's pre-existing, that's been collected for other purposes, but we're going to use it in order to conduct studies of drug safety and effectiveness. So this is just an example of what real-world data could look like, or a schematic example. So this is an example from a transactional database of healthcare records, and this is a given patient, and you can look at all of the different things that happen to a patient based on their healthcare records over a long period of time. So even if we just look at this small point in time here, all of the healthcare encounters that a patient has that's recorded in their healthcare records, and kind of blow it up here, we could determine whether they had a hospital stay. So you can see here a patient was in the hospital here. They received a diagnosis for a particular condition. Then they had a prescription that was given to them. They had a lab test result, and they might have had another 2 dispensed medications, and then they had another diagnosis. So by creating a longitudinal picture of all of a patient's healthcare encounters from real-world data or pre-existing healthcare data, we can create a full picture of all of the patient's characteristics, their potential medication exposures, and then their outcomes. And then we can take all of this information and actually conduct an observational drug safety study. So when we conduct a study using real-world data, we typically refer to the results of that study as real-world evidence. So real-world evidence is just evidence regarding the usage and potential benefits or risk of a medical product or a medication derived from the analysis of real-world data. So real-world evidence can be generated by different study designs or analyses. You can generate real-world evidence from pragmatic trials, but we're not going to get into that in this particular study, or in this particular lecture rather. We're focusing on real-world evidence that's generated from observational studies, which can be either from prospective or retrospective cohort studies, which I'll get into next. So now we're going to go into cohort studies in particular. So what is a cohort? Well, it's quite simple actually. A cohort is just a sample of individuals who are followed over time, and they're drawn from a particular source population. So essentially what you want to do is identify a population who's at risk of a particular outcome of interest that you want to study, and then you follow them over a given period of time. So for example, a particular source population can be based on a disease. So you might want to follow a group of people with myocardial infarction over time. So, here they could develop a myocardial infarction, then you want to follow them forward in time to see what happens to them. Or an example of another source population is like from the nurse, it's based on a particular occupational group. It's called, for example, the Nurses' Health Study, where they followed a group of nurses for a long period of time. So, you start off in the cohort because you're a nurse, and then you're followed forward in time to see what happens to you, or if you experience a particular outcome of interest. So there's a few different types of cohorts. There's a fixed cohort, which indicates that individuals can't move from one exposure group to another, and there's no loss to follow up. So an example of a fixed cohort is something like a birth cohort, where all people who were born in the year 2000, for example, are part of a cohort. You can never leave that cohort, because in order to be a member of that cohort, you need to be born in the year 2000. So that's an example of a fixed cohort. These aren't very common in observational drug safety research. So typically what we look at in pharmacoepi studies are dynamic or open cohorts. So these cohorts can gain or lose members who contribute to person-time experience for the duration of their presence in the cohort. So I'll get into that and what that means in the next slides. So a study population is also called the source population or the study base, and this is a defined population whose disease experience over a given period of time is the source of the study data. So inclusion in the study precedes the onset of disease or the outcome of interest. So for example, in the rofecoxib examples, you will probably be studying a group of patients with either rheumatoid arthritis or osteoarthritis, and you want to follow them forward in time to see if they experience an acute myocardial infarction. So you would want to select a group of patients who have a diagnosis of rheumatoid arthritis or osteoarthritis, who have not actually experienced an acute myocardial infarction. Then you follow them forward in time to see whether or not that particular outcome develops for those patients. But the study population or the source population is going to be something like people with osteoarthritis or rheumatoid arthritis. So there's two different types of cohort studies. The first type of study is called a prospective cohort study. And in this particular type of study design, you recruit patients first, and then you follow them forward in time until the outcome of interest occurs. We don't know the outcome status at the start of the study for a given patient. So an RCT is actually considered a special type of prospective cohort study where the exposure isn't assigned, because we recruit patients and then we follow them forward in time to see if they experience the outcome of interest or not. So in a prospective study, you start and enroll a defined population, then you observe their exposure status. So you could see, for example, whether or not their they're using a particular medication. So if they use rofecoxib, for example, or an NSAID, and then you follow these patients forward to determine, for example, if they experience an acute myocardial infarction. But at the start of the study, you don't know whether or not the patient has experienced the outcome of interest or not. You recruit the patients, then you follow them forward in real time in order to determine their exposure status and their outcome status. The other type of cohort study is called a retrospective cohort study. So in this particular type of study design, rather than identifying a cohort members now and then following them forward in time, in real time, you can actually identify members based on pre-existing information that was collected in the past. So you can see in the little schematic here that it's exactly the same as the prospective cohort study. You have a defined population, and then you observe their drug exposure status, and then after they've been exposed to a medication, you observe or have information on whether they've experienced the outcome of interest or not from an electronic medical record or from administrative health data, electronic claims data, but you're relying on pre-existing information. So you didn't enroll a group of subjects and then follow them forward in real time. You start off with pre-existing records and then analyze what their exposure status was in the past based on those records, and then what their disease status was in the past based on those records. You don't have to wait to see whether or not they've experienced the outcome of interest. It's already happened in the past. You're just actually analyzing pre-existing data that was collected in the past. Like, you can still establish temporality, and by temporality I mean, can you determine in the data whether or not the exposure occurred prior to the disease? You can do that based on, for example, information on when a patient was prescribed a medication and the date that they had a diagnosis for an acute myocardial infarction, for example. But you don't have to wait years and years for the patients to experience these outcomes in real time. You can look at pre-existing records. And this is what we do a lot in large database studies in pharmacoepidemiology. So, for example, a big database that we use is electronic medical records from the United Kingdom. So what we would do is we would start our data, the most recent date in the data set would be 2020, for example, and we'd evaluate pre-existing data from, let's say, 2000 till 2022, and we'd look at drug exposure, and then we'd look at whether or not a medication or a disease occurred within that time period. Like, the data is already pre-existing, the data is already there. And we can go in and look at exposure status and disease and figure out if a particular medication is associated with a particular adverse event, but we don't actually enroll a group of patients in 2020, for example, and then follow them forward until 2032 to determine whether or not they had the outcome. So it's based on pre-existing data that all occurred in the past. So this is just another little schematic representation of the difference between a prospective and a retrospective cohort study. So you can see from the little example that in a prospective cohort study, you look at the exposure and then follow patients forward in time, or you already have the information collected on the individual. So you're always determining whether exposure and outcome happened first or second. Like, what happened first, the exposure or the outcome? Like, that's easily identifiable in both prospective and retrospective cohort studies. It's just a matter of when that happened with relation to the current point in time that you're in. So don't get too caught up on this. People get confused by this. Just know that most of the time in pharmacoepi studies, we conduct retrospective cohort studies of pre-existing data that all of the exposures and outcomes have all occurred in the past, but we're just going into the data now to determine if there's associations between medications and outcomes. So a lot of the times in pharmacoepidemiologic research, you'll see that a particular study design called a nested case control study or case control sampling has been used. So this is a particularly confusing subject for students, and I don't want you to get too caught up on the details of it. I just want you to know that nested case control studies exist, and why are they used, what are they, and just so you can actually, when you read about it, you can understand a little bit more, like, oh, this is what a nested case control study is. So a nested case control study is still a cohort study. It's just a bit of a difference with respect to how the patients are sampled within your cohort. So in a typical cohort study, as I mentioned, you look at a group of patients, you have a study population, and then you follow them forward in time in order to determine whether or not they've experienced an outcome of interest. When you're using case control sampling within a cohort, or you're looking at a nested case control study, what you do is you identify cases, which are subjects with the outcome, within your defined cohort of patients, and then you identify a specified number of controls who are outcome free at the same time as the case occurs. And then you match on follow-up time and other patient characteristics. So for example here, this is our cohort of individuals that we're following forward in time. So 1, 2, 3, 4, 5. And in the first example, we see that they've experienced the outcome. It's red, so that's a case. And then if you move down that arrow, you see those blue dots are the controls. They're individuals who have not experienced the event of interest at that particular point in time. So you take a case and then you match them with control within your defined cohort. So the question becomes, well, why would we actually conduct this special type of case control sampling within a cohort? Why wouldn't we just look at all of the events, and then all the people who have an event, all of the people who don't have an event, and then you look at their exposure status overall, like you would in a conventional cohort study? Well, a lot of the time you would use this because you want to collect information on a variable that might not be available in the original data set. So you might have to review another source of data like a medical record or a questionnaire, or collect patient samples, like information on biomarkers, which is costly and time consuming. So you're only going to do this for the sampled cases and controls. So that's important to keep in mind, that within a cohort, if you're going to do case control sampling, you typically do it because you want to collect additional information on that particular patient. In the past, we used to conduct nested case control studies because they were computationally more efficient. So one of the first studies I did was a nested case control study because computationally I had a very large cohort with a lot of different events, and it was very computationally expensive and intensive in order to analyze that entire cohort of patients. So what I did was I looked at just the cases and the controls at a given point in time. Nowadays, this is less of an issue because of more advanced computing capabilities. It can still be very helpful for really large cohorts with a long follow-up. So you might conduct a nested case control study with really, really large cohorts with a long follow-up time, because computationally it's difficult in order to analyze the entire cohort in those types of analyses. So that's what a nested case control study is. It's still a cohort, but it's just a matter of how you sample individuals within that cohort. So just an additional note on case control sampling within a cohort. So in situations where you don't actually need to collect additional data, and you're limited to previously collected information, such as information within an electronic medical record or medical claims or insurance billing data, or we want to assess incidence and relative risk, a cohort design alone is typically easier to communicate and less prone to investigator error. Like nested case control studies are a bit more difficult of a study design to undertake, so that's why just a simple cohort study is typically better than a nested case control study. However, it's important to point out that like a well-designed and well-executed case control sampling design will provide valid estimates of a rate ratio, and it'll be the same as the rate ratios that you would get from analyzing the underlying cohort that gave rise to the cases and controls. So if you just conducted a study as a straight cohort study rather than a nested case control study, the nested case control study is done properly. It'll still give you the same results as if you had conducted the just regular cohort study. So it's not wrong to conduct a nested case control study. It's just a little bit more difficult to carry out, and it's more difficult to explain. So unless you have a really good reason to conduct a nested case control study, typically you just stick with a simple cohort study where you identify a group of patients, you identify their exposure status, and you follow them forward in time to determine whether or not they've experienced the outcome of interest. So I just really, again, want to point out that these nested case control studies are different than traditional community-based or hospital-based case control studies. So I didn't actually define what a traditional case control study was because we typically don't use them in pharmacoepidemiology. Typically we only we define cohorts of patients, and then we would conduct a nested case control study within that cohort if, for the reasons I mentioned earlier, we have to include additional information on those patients or it's computationally difficult. A nested case control study is very different than a traditional case control study in that a community-based or hospital-based case control study, we don't actually know what the true underlying source population is. So we don't actually observe our entire cohort of patients. Or we don't follow an entire cohort of patients in a traditional case control study. So as you can see from the diagram here, we don't have the long lines where we follow individuals from the start of follow-up up until the point that they experience the event of interest. All we have information on is whether or not a person has an event of interest, and then we have to find another control to match that individual with, and then we go back in time in order to determine the case and the control's exposure status. So typically we use this type of study design when we want to study a new disease and want to determine new risk factors. So for example, if you're looking at an environmental exposure, so if there's a bunch of people who are developing cancer, for example, in a community, you would probably conduct a traditional case control study where you go out and you find all of the cases of cancer, and then you find individuals who don't have cancer within the same community, for example, and then you would ask individuals about different types of environmental exposures, like are they working in a particular factory, or have they visited a particular part of the community, or are they using their water from a particular source. That's not a cohort study. We haven't enrolled a group of patients or individuals, and we haven't followed them forward in time. In this traditional case control study, I'm just finding cases of cancer within a community, and then I'm finding controls, so people within the same community who haven't experienced cancer, and then I'm going and measuring their exposure status just prior to that to understand whether or not there's an environmental risk factor for an outcome in a community or something like that. So that again is different than a nested case control study where, yes, we're sampling cases and controls, but it's within an overall cohort. We know the total number of people in the cohort, and we know how long we followed individuals for. In this traditional case control study, that's not the case. We don't know how long we followed people for. We don't have person time of follow-up. We don't have the total number of people that are in a particular cohort. So don't get too caught up on this. Everybody gets very, very confused about the difference between a traditional case control study, a nested case control study, a cohort study. The take-home message is, typically in pharmacoepi, we use cohort studies. We're following an entire group of patients from start till end for a given period of time. And then sometimes within cohorts, we might use case control sampling is another way we do a pharmacoepi study, but typically we don't use these traditional case control studies in pharmacoepi, but it's just important to understand what they are in order to understand why we don't use them in pharmacoepi. And the reason we don't use them in pharmacoepi is because typically we have these huge pre-existing healthcare databases that we can use to answer all of our drug exposure outcome questions. So why would we go through a case control sampling strategy when we really don't? It's not the strongest study design for most of the questions that we're asking. So I hope that that's clear. So that's just a quick overview of some of the more traditional study designs in observational studies or epidemiology. And in pharmacoepidemiologic studies or studies of drug safety, the most common study design you'll see is going to be a retrospective cohort study of pre-existing healthcare data. It's not the only type of study design that you're going to see, but overall, that's the most common type of study we're going to see is a retrospective cohort study where we identify a group of patients within pre-existing healthcare data. We then identify their exposure status using this pre-existing healthcare data, and then we also measure their outcome status. And then we conduct an analysis to determine if there's an association between a particular medication of interest and then an outcome. And I'll get into the analysis later on. But first, I want to talk about some of the errors that can occur in study designs of observational studies. So I really want you to kind of relate this back to what we learned in the trials lecture. All of the different errors we're going to see are the same errors that we saw in the RCT lecture. However, how they occur and what we do about these errors in observational studies is slightly different, but just think back and relate it back to what you know about RCTs to help you better understand this section. So this just kind of gives us a sense of what we're actually trying to calculate whenever we're conducting a study, and how bias and error in the study can interfere with the good conduct of a study. So anytime we're conducting a drug safety study or a study of drug efficacy or safety, what we're really trying to do, like the goal of the study, is to determine the causal measure of effect. You want to determine if there's a cause and effect relationship between a medication or an outcome. So for example, does rofecoxib cause an increased risk of myocardial infarction compared to another NSAID? But a lot of the time, when we're conducting a study, we introduce all these different layers of bias and error. This kind of moves us away from this true causal measure of effect to more of a measure and an association, where typically when we're conducting an observational drug safety study, we talk about causal measures of association, and in randomized controlled trials, we talk about causal measures of effect. And the reason we do this is because in randomized controlled trials, things like confounding, information bias, and most of the time selection bias and random error are less of an issue because randomized controlled trials are so rigorous with respect to preventing all of these different issues. But in observational drug safety studies, when we're conducting a retrospective cohort study of pre-existing healthcare data, there's sometimes less we can do about these errors. There's still a lot of ways to prevent things like confounding, information bias, etc. in observational studies, but that's why we tend to refer to the measures we calculate in terms of the effect of a medication on an outcome in an observational study as a measure of association. So that I hope that's clear, that ultimately our goal is to calculate cause and effect relationships, but when we introduce error into our study design, or there's error present in our study, then it moves us closer to a measure of an association, which can be close to a measure of effect, or can be way off if the study is very, very biased. So I think this will make a bit more sense with the following slides. So this is a slide that I showed in the RCT lecture. when we talk about error, study design error that can occur in a study. So error can be made up of two different components. Random error, which is a statistical concept that, we just observed a particular outcome or association by chance. And then there's systematic error, which includes selection bias, confounding, and information bias. And all of these together are referred to bias overall. And precision is known as a lack of random error, and then validity is known as the absence of bias or systematic error. And we'll recognize now precision, we talk about a lot with respect to confidence intervals, remember. So if we have a precise confidence interval, it means that it's very tight around the measure of effect or the point estimate that we've calculated, and there's not a lot of random error in our particular study. So we're not going to be talking about that in this section. We've already talked about that in our statistics section. In our measures of effect lecture, we're going to be focusing on systematic error in these slides, but in particular systematic error as it occurs in observational drug safety studies. So one of the most important types of bias that can occur in an observational study is called selection bias. And we can remember back to our RCT lecture that selection bias is mainly the result of loss to follow-up. Which in the context of an observational study, selection bias is defined as selective inclusion into the study of subjects who are not representative of the exposure or outcome distributions in the source population. So this is just a fancy way of saying that the sample of patients that we include into our study are not representative of the exposure and the outcome distributions in the main target population that we're trying to make inferences about. So typically, selection bias is more of a problem in prospective cohort studies when we actually have a possibility to lose patients to, there's loss to follow-up. But in a retrospective cohort study, this is less of an issue. Selection bias is typically more the result of excluding certain patients from your study population that maybe should have actually been included in your study. So that's one way that selection bias can occur in an observational study. But one of the more one of the more common types of selection bias that we come across in observational studies is self-selection bias. So this simply refers to the fact that subjects or patients who choose to use a particular treatment may be systematically different than those who do not use a particular patient or who do not use a particular treatment. So this can lead to a non-representative, unexposed group of individuals, or something called a healthy user bias. So, for example, this is a pretty famous study of self-selection bias. So hormone replacement therapy was used for older women because it was thought to decrease the risk of issues related to menopause. But it turns out that it's actually associated with an increased risk of coronary heart disease. However, this was difficult to determine initially in observational studies because it turns out that women who use or choose to use hormone replacement therapy tend to have a higher socioeconomic status, were less likely to be overweight, were more health conscious compared to women who weren't taking hormone replacement therapy. So this represents selection bias because in the unexposed group of people, you tend to have sicker individuals, and in the exposed group, you're missing that entire group of sicker individuals because typically healthier women tend to use hormone replacement therapy. So that's why it was difficult to uncover this link between hormone replacement therapy and the risk of coronary heart disease. So that's one example of self-selection bias. Another example is influenza vaccine and all-cause mortality. So, people who choose to receive an influenza vaccination tend to be healthier overall, and this is, again, prior to COVID. So people who get their yearly flu vaccine, they tend to be healthy overall, and they also tend to have other types of healthy behaviors, like going for breast cancer screening, compared to those who don't get a yearly influenza vaccine. So people who get the influenza vaccine are systematically different than those who don't. They're generally healthier overall. So in our exposed group of people, we're missing this kind of unhealthy group of users who are all in the unexposed group. So this can again lead to self-selection bias, which is a form of selection bias overall. So prevalent user bias is another really important bias in observational studies, and in particular pharmacoepidemiologic studies. So prevalent user bias occurs when prevalent drug users or current users of a medication are included in an observational study. So prevalent users are defined as patients who are already taking a therapy for some time before the study starts. And this is an issue because people who have been using medications for a long time or prevalent users of a medication are defined as survivors or healthy users for that period of pharmacotherapy. Because this can introduce selection bias if the risk of adverse events varies with time. In this case, you're going to exclude early discontinuers of a medication because of adverse events, and this is called depletion of susceptibles. So overall, all this means that, patients who have been using a medication for quite a long time are probably very different than patients who used it for a short period of time and then had an adverse event. Of course, the people who have been using it for 10 years, they've been healthy. They haven't experienced any issues with the medications, so they've continued to use it. So those people are going to be very different in the group of patients who starts off using a medication, since people tend to discontinue use of a medication because of a lot of different reasons. So this is called a prevalent user bias. So ways that we mitigate selection bias in pharmacoepi studies related to self-selection bias and prevalent user bias is the use of a new user active comparator design. So what this means is that we select individuals who are new users of study medications right at the start. That's part of our study cohort selection, which produces comparable treatment groups with clear definitions for when their treatment starts. And then you also compare two treatments with the same indication for treatment. So in your intervention group, for example, you're going to have one medication, and then in your comparator group, you're going to have another medication that has the same indication for treatment. So it treats the same disease, and it needs to be a relevant comparator for the particular clinical context that you're looking at. So that's one way we mitigate selection bias and have more comparable groups that we're comparing, is this new user active comparator design. New user, again, is people who have never used the medication before. They just started using it, and there's a clear start date for their medication. So we're starting off with new users who are very similar in terms of or who are more similar in terms of their characteristics compared to a new user and a prevalent user of a medication. And then you also include an active comparator in your control group. So again, another medication that's used in everyday clinical practice to treat the same indication as the medication that you're investigating. So as we're talking about all these different observational study designs, it's really important to point out that avoiding bias in our study design, the best way to do it is to try and do something that we call emulate the target trial. So the best way to actually design an observational study is to actually envision a target randomized controlled trial that you would want to conduct if it were logistically and ethically possible. And emulating that target trial design in the design of an observational study, even in the absence of baseline randomization, helps to avoid different design biases and improves clarity around your study design. So even though we're not able to actually conduct a randomized controlled trial, we try to design an observational study in a similar way to if we were able to conduct our ideal randomized controlled trial, how we would go about doing it. And going back to our active comparator new user design, like in a randomized controlled trial, we try to or we do enroll patients who have never used the study medication before, right? Because we enroll a group of patients and then we randomize a medication, either the intervention or control, to those patients. So that is essentially the new user design in an observational drug safety study. And we also always include a comparator, right? Either the placebo or an active comparator, this is why we're using an active comparator as well in our observational drug safety study. So just keep that in mind, that the more we try and emulate this ideal target trial in the design of an observational safety study, the less likely we are to introduce bias into our study design. Information bias is another really important source of bias in observational studies. It's also known as misclassification. So information bias can arise when incorrect information about either the exposure, outcome, or covariates or patient characteristics is collected, or variables are incorrectly categorized. So again, we want to think about this in the context of real-world data sources that we use to conduct observational studies and obviously measure our exposures and outcomes. So information on diagnoses, procedures, and medications recorded when interacting within the healthcare system is what we use in order to measure our exposures and our outcomes. And this can lead to information bias when these sources of information don't correctly capture those different variables that we're trying to measure. So to specifically narrow in on sources of information bias, with respect to exposure misclassification, this essentially is our measurement of our exposure variable and how accurate this is within our study and our given data sources. So it's essential to accurately measure the start and end of a given drug exposure. So typically we use pharmacy dispensing records in order to measure drug exposure for a given individual. However, mismeasurement can be introduced into this measure because daily dose or the day supply might be wrong in the dispensing records, or the patient might not actually take the medication that they pick up from the pharmacy. Immortal time bias can also lead to misclassification of exposure time. Don't worry about this too much. It's a little bit of an advanced topic for this class. We talk about it a lot in pharmacoepidemiology, but all it means is that you're not correctly identifying the length of time that a patient is exposed to a medication. So just know that it's related to the amount of time a patient's exposed and correctly classifying that. But all of these together can lead to exposure misclassification. Outcome misclassification is related to mismeasurement of our outcome variable, or to the disease or outcome we're trying to look at in our study. So a lot of the times outcome misclassification arises because the databases or pre-existing databases we're using in order to measure our outcomes of interest lack detailed clinical data. So typically we use diagnosis codes in order to measure diseases. So these are ICD codes, typically International Classification of Disease Codes, or READ codes if we're looking at data from the UK. But use of these codes can sometimes lead to false positives and false negatives, especially for conditions like something like migraine that are especially difficult to measure using these types of diagnosis codes. So that's when outcome misclassification and information bias can occur when we're trying to measure our outcome. Confounder misclassification is simply misclassification or missing confounder information, which leads to residual confounding. So this is just mismeasurement or inability to measure important patient characteristics in the study that we're looking at. So confounding is another really important source of bias in observational studies, and of course we heard about this in our RCT lecture, but just to refresh the definition for everybody. So confounding occurs when the measure of association we're looking at, so for example, the association between a diabetes medication and heart failure, it's distorted. This association is just distorted by the presence of another risk factor from the outcome. So a confounder has to be associated with both the exposure and the outcome without being in the causal pathway or an intermediate. So typically what we do to start thinking about potential confounders for our research question or our association of interest is to start off with risk factors for the outcome. So in this particular example here, obesity is a confounder of the association between diabetes medications and heart failure, because obesity, whether you're obese or not, influences what type of diabetes medication you're going to receive. And obesity also influences the risk of, it increases the risk of heart failure. It's a risk factor or a prognostic factor for heart failure. So given that obesity is associated with both choice of a diabetes medication and heart failure, it's typically an important confounder in studies where we're looking at the association between diabetes medications and heart failure. We have to account for it in our analysis. So in pharmacoepidemiology, in particular, we tend to talk about confounding by indication and channeling of treatment to particular patients. This is a specific type of confounding that we talk about in observational drug safety studies. So we know that in clinical practice, treatment selection or medication selection is typically done according to a patient's disease severity or their prognosis, and this can result in bias. Typically, if we want to understand how a patient's characteristics influence how they're prescribed a particular medication, or this is called the channeling process, you typically have to consult physicians or look at clinical practice guidelines or look at drug utilization studies to really understand this. So if meaningful imbalances in key prognostic factors or confounders or patient characteristics raise concerns, it can actually limit, you can limit the study to a more homogeneous patient population or restrict to a particular sample that actually excludes patients with particularly strong confounders from the analysis overall. So this is one way to deal with confounding by indication or channeling. So as I mentioned previously, restriction is one way to deal with confounding by indication in your study, and I mentioned it at the beginning of this slide here, but there's also other ways to account for confounding in your study. So you can conduct a stratified analysis. So this just means that you evaluate your exposure outcome relationship or exposure disease relationship within each stratum of a particular confounder. So if sex is a confounder of a particular exposure outcome relationship, you might want to analyze or calculate the relative risk for the medication and the outcome in men and women separately. So this removes the confounding effect of sex in your analysis. But the most common way to deal with confounding in a study is using a multivariable analysis, where we actually adjust for confounders in statistical regression models, and propensity score methods are another way to do this or account for confounding in multivariable models, and I'll get into the details of that here. So multivariable models are really important in observational drug safety studies, but I don't want you to get too caught up in the details of all the different multivariable models and how they work. I just want you to understand why we use them and the general a general idea of what a multivariable model is and the purpose. I don't want you to get too stuck on any of the statistical details or anything like that. Just focus on why we use them and the purpose. So why do we use multivariable models in the first place? So in our previous lectures on clinical trials, we just calculated the crude risk and rate differences and ratios using the crude events in order to answer a research question of interest as to whether or not a new medication was associated with an increased risk of an adverse event compared to a control medication. But why don't we just stop here in order to answer a research question of interest in observational studies? Well, that's because confounding is an issue. Recall in randomized controlled trials, we randomize treatment and in order to make our intervention and control groups comparable with respect to measured and unmeasured confounders. Confounding is not an issue if randomization has been done properly, allocation is concealed, and blinding is successful throughout the trial, and there's not a lot of loss to follow-up. So we don't have to worry about differences in confounders between our intervention and control groups in randomized controlled trials. But in observational studies where treatment is not randomized, it's simply prescribed by a physician giving a patient's characteristics, confounding is an issue. So from our rofecoxib NSAID case study example, we want to determine whether there's a difference in the risk of myocardial infarction among those using rofecoxib compared to those using other NSAIDs. So those who are taking rofecoxib or who have been prescribed rofecoxib tend to be different with respect to race and prevalence of hypertension and other characteristics compared to the use of other NSAIDs. And these characteristics are also associated with a risk of myocardial infarction. So we'd say that there's confounding occurring, and we need to account for it. So analysis of covariance or adjustment is the preferred method to deal with confounding rather than stratification, especially if continuous confounding variables are present or there's many adjustment variables. If you're looking at stratification, you can only deal with one confounder at a time, whereas statistical adjustment in a multivariable model allows you to deal with accounting for multiple confounders at the same time, and as well as continuous variables. So examples of models or multivariable models includes things like multiple linear regression, which is used when we have a continuous outcome variable. Logistic regression is used when we have a binary outcome variable. So do you have a myocardial infarction, yes or no? Cox proportional hazards models are used when we have a binary outcome variable, but we also have information on the time to event. So the time to myocardial infarction, yes or no. And then Poisson models are used when we have a count outcome. So if we weren't looking at myocardial infarction, yes or no, we were looking at the number of myocardial infarctions you had. So did you have 0, 1, 2, 3, or 4 myocardial infarctions? So with multiple linear regression, we tend to calculate adjusted risk ratios. In logistic regression, we can calculate adjusted odds ratios. In Cox proportional hazards models, we calculate adjusted hazard ratios. And in Poisson models, we calculate adjusted incidence rate ratios. I'm not going to get into, there are differences, of course, between all these models and the assumptions and the methods used to calculate each of these models. I'm not going to get into them. Just know that you calculate the adjusted measures of association as a result of all these models, which are interpreted in the same way, essentially, to one another, and they're interpreted in the same way as we would interpret our crude risk ratios or crude rate ratios from the 2x2 tables that we had worked on in the earlier measures of effect lecture. So again, you don't need to worry about the details of this or the model or memorize any of this, but multivariable models, essentially they just allow us to estimate the association between the exposure or outcome holding other variables, in other words, our confounders constant or adjusting for these variables. And we provide or we include the full set of confounders in our model in order to correct for confounding. So one of the x1 variable would be our exposure in our model, and then the x2, x3, x4, etc. variables would be all of the confounders in the model. The y hat is the outcome. So we're going to estimate the effect of the exposure on the outcome after adjusting for or accounting for all the other confounders using a model like this. That's how multivariable regression works. So how do we select all those x variables or confounders to include in our multivariable models? So again, we want to include confounders in our model. So these are variables that are associated with both the exposure and the outcome. But how do we actually determine which variables are confounders for our particular research question or our association of interest? Well, it really depends on the research question, but you really need to understand the subject matter of the research question that you're evaluating, and not only consider statistical tools for selecting confounders. Again, you have to look up the subject matter and the disease that you're studying. Typically, you want to look at like quick resources online to see what might be useful confounders for your particular health-related question of interest or your disease of interest and the medications that you're looking at. Intermediate shouldn't be included as confounders. So these again are variables in the causal path between your exposure and your outcome. And variables that are associated with the treatment alone, your medication alone, and not the outcome should not be included in the model. So take-home message for all of this, you have to understand the outcome or disease that you're trying to look at as your outcome of interest. And a good place to start out is just with a list of risk factors for the outcome and then go from there. So again, going back to our case study, if we're looking at myocardial infarction as our outcome, and we're looking at the association between rofecoxib and myocardial infarction compared to other NSAIDs, we'd want to look at risk factors from myocardial infarction. And we would consider these risk factors as potential confounders in our rofecoxib myocardial infarction association study. So let's think, what are some risk factors for myocardial infarction off the top of your head? Risk factors, prognostic factors, again, these are all the same sorts of things. So age, we know that age is a risk factor for an MI. Sex, men are more likely to have an MI typically compared to women. If you have high cholesterol levels, high blood pressure, if you're obese, those are all risk factors for myocardial infarction, which should be considered as potential confounders when you're looking at the association between rofecoxib and myocardial infarction. So just to give you a quick overview of some of the most common statistical models that you're going to encounter in pharmacoepi studies. So the first one is called logistic regression, and we use logistic regression when we have data on a dichotomous outcome or a binary outcome. It's a yes-no outcome. So typically we use it when we're trying to analyze the results of a nested case control study, but it doesn't incorporate information on time to the outcome. It's just whether or not you have the outcome, yes or no. And in using this model, we tend to calculate odds ratio. So OR is an odds ratio. So we're calculating an odds ratio, which let's just think of it as the equivalent of a risk ratio, similar to what we were calculating in our 2x2 tables in the measure of effect lecture. They're not the same thing, but for the purposes of this class, they can be interpreted very similarly. So if you have an odds ratio that's greater than 1, similar to the way we would interpret a risk ratio greater than 1, we would assume that our exposure of interest is associated with an increased risk of whatever our outcome is, compared to whatever the comparison medication is. If our odds ratio is less than 1, this suggests that there's a decreased risk with our study medication or exposure of interest compared to our comparator medication. And if the odds ratio is equal to 1, then we assume there's no association or no difference in the risk of the outcome between the treatment groups. And again, don't forget we want to include our confidence intervals around our odds ratio typically when we're interpreting, or in order to fully interpret our odds ratio of interest. So that's just an odds ratio. Another really common statistical model that you're going to encounter in a lot of different pharmacoepi studies is the Cox proportional hazards model. So all you need to know is this model is used when you have information on a time to event. So you have time to event outcomes, so time to myocardial infarction. And typically you use a Cox proportional hazards model when you are conducting a cohort study. So similar in the logistic regression model, that's the measure of association that's calculated, the odds ratio in a logistic regression model. We calculate hazard ratios in Cox proportional hazards model. And again, these hazard ratios are interpreted in pretty much the same way as we'd interpret a rate ratio, again, from our 2x2 tables in the measure of effect and association lecture. So, and in the box here, yeah, it says a hazard ratio can be interpreted like a risk ratio, but technically it's different. But don't worry too much about the details around that. Just know that logistic regression and Cox proportional hazards models are very common multivariable models used in observational drug safety studies. The measures of effect calculated from a logistic regression is an odds ratio. The measure of effect or association calculated from a Cox proportional hazards model is a hazard ratio, and we interpret these measures in the same way as we'd interpret a risk ratio or a rate ratio that we talked about previously. So again, don't worry too much about propensity scores, but just so you know what they are when you read about them in a study, because they are so common in pharmacoepidemiology. Sometimes we have a lot of different confounders that we want to adjust for in our model, but we just don't have the sample size or number of events to have enough statistical power to do this. So in that particular situation, we would look to calculate something like a propensity score, which includes all the confounders in a model that we want to adjust for in a particular score. And then we just adjust for this score in our model. We can also stratify by the score or match on it. That's another technique that you'll see a lot in pharmacoepi studies. But just know that propensity scores are another way to adjust for a large number of confounders when you're looking at the association between a medication and a particular outcome. Okay, so now I want to take all of the theory that I just taught about observational studies using real-world evidence and kind of pull it all together using a case study of cyclooxygenase 2 inhibitors and acute myocardial infarction in older adults. So again, COX-2 inhibitors are rofecoxib medications, are Vioxx medication, where initially in the phase 3 clinical trials, we looked to see whether or not these medications reduced pain and inflammation among patients with rheumatoid arthritis and osteoarthritis. We also looked to see if they improved safety outcomes with respect to GI events. And then the medication was brought onto the market. But then there was a safety signal with respect to the cardiovascular safety of these medications and the potential for these medications to increase the risk of certain cardiovascular events, including myocardial infarction. So that's kind of the justification and the background for going ahead and conducting a phase 4 study, a post-marketing drug surveillance study of these medications in the real world setting using pre-existing data. So I'm just going to go through this particular study quite quickly. So the authors outline in the background section that COX-2 inhibitors, or COXIBs, were developed to cause less GI hemorrhage than non-selective, non-steroidal anti-inflammatory drugs. Those are the NSAIDs. But there's been concern about their cardiovascular safety, as I mentioned. So in this study, they looked at the relative risk of acute myocardial infarction, AMI, among users of celecoxib, rofecoxib, and NSAIDs. So the two COXIBs are the the cyclooxygenase 2 inhibitors, and this was among Medicare beneficiaries with comprehensive drug benefits. So I'm going to get into the details of that in the next slide. So with respect to the patient population or study cohort for this study, the first paragraph essentially just outlines that these patients were from the U.S. and that they were part of the Medicare health insurance policy. So they're just those that are insured by a particular health insurance policy. So from this pool of eligible Medicare patients, the study authors excluded patients who had illness that might have obscured any potential relationship between coccidiosis and AMI. So that's very general. So these included persons with a serious life-threatening illness, including HIV or AIDS or malignancy, and persons with coagulopathy issues. They also excluded persons with a hospitalization during 1998 who received a diagnosis of AMI that was not the principal discharge diagnosis. And people who were without information were excluded from the study. So this is just a fancy way of saying that they took a group of people who had a particular health insurance plan. They excluded people who weren't expected to live for a long amount of time, those who had a pre-existing acute myocardial infarction, and that was their study cohort, essentially, or their study population that they then followed over time in order to observe their exposure status and their outcome status to answer their question with respect to the effect of or the association between coccidiosis and acute myocardial infarction compared to NSAID users. So in order to measure the outcome of interest for this study, the outcome of interest being acute myocardial infarction, the case definition that the authors used was a hospitalization in 1999 or 2000 with a discharge diagnosis of acute myocardial infarction using an International Classification of Disease 9 code of 410 in the first or second position. So all this means is that they looked at diagnoses codes for pre-existing hospital data and looked to see whether they had a code that indicated whether they were in the hospital because of an acute myocardial infarction. So the length of the hospital stay for the AMI had to have been at least 3 days and no more than 180 days unless the patient died. And this was an accurate algorithm in order to identify acute myocardial infarction in another population, so they thought it was valid for this particular study. I think that those are all the details that I want you to take away from this particular section. But just know that they use pre-existing hospital records in order to identify patients with acute myocardial infarction using diagnosis codes. That's the take-home message, but you can read this section in more detail if you would like. In order to identify exposure in this particular study, the study investigators needed to identify use of coccidiosis and non-selective NSAID use. So they looked at all prescription drugs filled by eligible patients, including the drug name, dosage, frequency, and day supply. So when they mean they looked at filled prescription drugs, what they did was they likely looked at billings from health insurance when a patient goes to the pharmacy and picks up their medication. They have information on that, and then they use this information in order to infer whether or not a patient is exposed to a particular medication. So they say here the exposures of interest were the use of celecoxib or rofecoxib on the index date. I think that that's all the important information I really want you to take home from this. Again, there's lots of different detail in this, but all I want you to know is the way that they identified exposure was through pre-existing medication claims data from the pharmacy. That's how they identified medication use for a given patient, using that pre-existing data. So with respect to the confounders or covariates that were included in this particular study, the authors mentioned that the covariates are defined on the basis of data from the year before the study period. So I believe this is in the year prior to the index date, which I think is the first dispensation of one of the study medications. What's important to know from here? So here they list the covariates. The covariates assessed include age, gender, race, previous myocardial infarction, angina, coronary artery revascularization, that one's a hard one to say, congestive heart failure, ischemic cerebrovascular accident, diabetes, hypertension, use of lipid-lowering drugs such as a statin, use of hormone replacement therapy, use of an anticoagulant, and use of NSAIDs, previous use of NSAIDs, rheumatoid arthritis, osteoarthritis, presence of a hospitalization, number of visits for ambulatory care-sensitive conditions, and number of medications used. So essentially, this is just a very long list of risk factors for acute myocardial infarction that the authors hypothesized might also be associated with the type of COX-2 inhibitor or NSAID that was used. So in the second paragraph, they give additional details on it, but that's what I want you to focus on, is the set of confounders that the study authors started off with were just a set of risk factors for acute myocardial infarction. So with respect to the analysis that was done in this particular study, we can see that in the first sentence, the authors mentioned that the distribution of covariates was assessed in each exposure category. So that just means that they looked at the association between each confounder and each exposure variable to see if they're associated with each other. So in this particular study, they mention, in this big line here, that all covariates were tested in multivariable conditional logistic regression models, conditioning on all matching factors. So that just means that they included all of the confounders in the previous slide into their logistic regression model in order to adjust for those particular confounders. Then they go through this whole process of model building using statistical techniques. For this technique has actually gone out of fashion quite a bit. So for this, I just want you to focus on the fact that they have used a logistic regression analysis, and the set of confounders that was mentioned in the previous slide was included in this logistic regression model in order to adjust for them. And the rest is a lot of other details, but that's what I want you to take away from this particular analysis paragraph. So moving on to the results of the study. So similar to what we see in our randomized controlled trial for our table 1, we have a table of baseline characteristics overall, and then stratified according to the exposure categories. So actually they don't have an overall column in this particular table, but we can see that all of the patient characteristics are described according to each exposure category, which includes celecoxib, rofecoxib, naproxen, ibuprofen, other NSAIDs, and no current exposure, which is actually a huge category. So what we would do when we're looking at this particular baseline table of characteristics, we'd see or note any huge differences with respect to characteristics between the different exposure groups. So again, when we're doing a randomized controlled trial, exposure is randomized. So we would expect there to be balance with respect to patient characteristics between an intervention and control group. Whereas in a observational drug safety study, again, medications are prescribed to patients based on their characteristics. So there may not be balance in characteristics between the different treatment groups. So for example, if we look at hypertension, history of hypertension, we could see that about 64% of patients in the celecoxib group have hypertension, about 65% in the rofecoxib, that's pretty similar. 61% have hypertension in the naproxen group, 59% in the ibuprofen group, 63% in the other NSAID group, and then 56% in the no current exposure group. So we can see that among users of NSAIDs and these COXIB medications, the prevalence of hypertension is relatively similar, but in patients who are using none of these medications, it's a bit different. It's a little bit lower. So that's the type of information we'd want to look for in a table 1 of baseline characteristics. And finally, when we look at the results of the primary analysis for this study, the authors included a table 2, which includes the adjusted association between COXIBs and acute myocardial infarction. So these adjusted odds ratios are the odds ratios that came out of the logistic regression model that included all of the confounders in the model. So these aren't the crude odds ratios that we would, typically calculate in our 2x2 table, just looking at the event rates or just the events and the number of patients in each group. These are the adjusted odds ratios. So the measures of association that we calculate for the association between a given medication and an outcome after adjusting for all the patient confounders. So in this particular example, we would interpret an odds ratio in the same way we would interpret a risk ratio. So for the first line, we can see here that the odds ratio for rofecoxib compared to celecoxib for the risk of myocardial infarction is 1.24, with a confidence interval ranging from 1.05 to 1.46. So in order to interpret this adjusted odds ratio, I would say there's a 24% increase in the odds or the risk of acute myocardial infarction with rofecoxib exposure compared to celecoxib exposure after adjusting for important patient confounders. That would be the first part of it. And then I would interpret the confidence interval, and I'd say the increase in the risk might be as low as 5% or might be as high as 46%. The data is compatible with between a 5% and a 46% increase in the risk of myocardial infarction with rofecoxib exposure compared to celecoxib exposure after adjusting for patient confounders. So it's a slight difference in the way we interpret these measures of association in an adjusted multivariable analysis. So, and then we can interpret all of the other odds ratios. So, for example, let's look at another one here for the celecoxib compared to the other NSAID comparator. We can see that the adjusted odds ratio is 0.95, confidence interval ranging from 0.82 to 1.1. So I would interpret this adjusted odds ratio as there is a 5% decrease in the risk of myocardial infarction with celecoxib compared to other NSAIDs after adjusting for our set of patient confounders. However, the confidence interval suggests that the data is compatible with approximately, I think that's doing some quick math in my head. I think that's an 18% decrease there. Let me just make sure. Yeah, so with between an 18% decrease in the risk of acute myocardial infarction up to as high as a 10% increase in the risk of acute myocardial infarction with celecoxib exposure compared to other NSAIDs. Therefore, we can't make any conclusions with respect to whether there is an increase or a decrease in the risk of acute myocardial infarction with celecoxib exposure compared to other NSAIDs after adjusting for our set of patient confounders. So I hope that going through the results of this little case study has helped to bring some of these concepts together for you that I've taught about observational drug safety studies, and I'm happy to answer any questions you have about this in our observational studies seminar.